Started, I always like to just remind everybody that I'm very appreciative of Beaver County Behavioral Health, who sponsors this series, this training series for providers, and allows us to provide it for free. And that's one of the greatest things about training credits, right? I'd like to say you all come because it's me, but a lot of you come because it's free. And technology is not always my best friend. Okay, so today we're talking about suicide, specifically for the co-occurring culture. And we're going to talk a little bit about that, how it looks different this year when we talk about suicide because of the pandemic. And so we'll talk about that a little bit. As always, I encourage you just to take a moment, and I invite you just to breathe. Since, like I said, several of you are probably going to multitask today, and that's perfectly fine with me. I will emphasize points that I really want you to take. If you hear me say, really listen to this, then maybe stop for a moment and really listen. But otherwise, but before we get started, just take a moment and breathe. It's one of the things that we forget to do that is so helpful and healing for our head and our heart. And particularly today, this, like I said, is a very heavy topic. And so I think to kind of breathe and allow yourself some space, knowing that it's going to be a little bit difficult topic, is important to get us started. So deep breath in, deep breath out. Moving on. With this series, I always like to just take a moment to remind you that what we're looking at with our world is different than any other year we've ever looked at it. And that this is very unprecedented is the word that we keep hearing, that we've just never seen this before. I think it's important to remember that you and the people that you work with are responsible for a lot of people and a lot of things in the world. But things are important, but people are really important. Each individual soul that you're responsible for, whether it's yourself, your family, your coworkers, your clients, all of that is really, really important. And so I always like to take a moment at the beginning here just to tell each and every one of you, in case no one else tells you today, that I really appreciate all the work and dedication that you have. We are the type of workers that have been continuing to work through the pandemic. We haven't really had much of a break, if any. And in some ways, we've been busier than ever. So I really do appreciate, and so do a lot of other people appreciate the work that you're doing. But it probably doesn't get said as often as it should. So I wanted to make sure that I got to say it today. So talking about the pandemic, whoops, I just messed something up here. Give me a second. Talking about the pandemic. There we go. Maybe. Hang on. Yeah, I can't seem to get my slideshow. There it is. Okay. Sorry. Technology, not always my friend. We are going to be talking about co-occurring disorders today, and we're going to be talking about suicide in that context. But we do have to remember that this year is a little bit different with the pandemic. And so just a couple reminders we've been going through just to give us some parameters and how to look at this in regards to the pandemic. So one of the biggest things that we're all going through is grief. That's one of the things that is common to each and every one of us throughout this pandemic, is that the life we're living today on October 28th, 2020 is not the life that we were living October 28th of 2019 or any other year. And so that brings with it some grief, and those stages of grief, anger, depression, bargaining, denial, isolation, some acceptance, are kind of all over the board. And that's why I like to use this diagram, because it's a little chaotic, and that's what our grief tends to look like. I think it's important we remember that we're all going through that, and then others around us are going through that. And think of it in the context of suicidality, grief can be a big contributor to that if it's not able to heal on its own, and to heal in a good, positive way. So we want to keep that in mind and remember that. We also want to remember things about this particular pandemic and this crisis, is that nothing is really normal. With things we used to count on, we can't really count on anymore. There's lots of uncertainty in the world, and now we're coming up on, I guess, the third wave of the virus potentially. And from what I read recently, it's looking worse than the second wave, but of course not as bad as the first wave, which is good. But that leaves lots of uncertainty about what's going to happen physically, financially, economically, emotionally, all those types of things. And particularly, I think with the upcoming holidays, uh, what's Thanksgiving going to look like? What's Christmas going to look like? What's New Year's going to look like? Those types of things are really very uncertain and lots of unknowns right now. So people in general, ourselves included, have significant concerns about, are we going to be able to meet our needs? What's going to happen with our jobs? What's going to happen with our food, our toilet paper, our social connections, and things like that. So there's lots of stressors out there. These stressors are impacting each and every one of us, but remember that they're particularly hard on people who have a history of mental health issues, have a history of substance use issues, or have a history of trauma. And of course, the more, if they have multiple of those, if they have some mental health issues and substance use, then that's going to be even more difficult. So we want to just remember that in context of what's going on. Real quickly, this is a graph. You don't need to look at the specific numbers, but this is out of one county in Texas where they did some really good data on suicidality. And if you can see, they went week by week. This is this year. This is from starting February 2nd, which was kind of pre-pandemic or kind of very beginning of pandemic. We really didn't know what was going on yet. We didn't see the severity of it yet. And then into the first week of March, you can see suicides, completed suicides in that one little county increased pretty significantly. And that's pretty consistent across the country. So we don't have a lot of really great numbers yet about how suicide has changed during the pandemic. We just know it has increased, and those numbers, we'll get good data. It's just, data sometimes takes a little while to come out and make sure it's credible. But just when you think about the pandemic, just know that February to March, things really changed. And those changes have continued in the context of what we're talking about today. So just a reminder of what does co-occurring disorders look like, and it can really vary. So there's no one particular look, and I think that's important for us to remember, is that co-occurring disorders look like any one of us. There's no label that we wear on our forehead that says I have co-occurring disorders. And so we have to kind of really do good screening and assessment sometimes to find it. But we know a lot more about it now, which is a really good thing. I have this quick video. I'm hoping that it's going to play. Jen, you'll have to tell me if you can't hear it, then you'll have to tell me. But the video is about stigma, and I thought that was important to focus on a little bit today when we're talking about suicide, because there is a lot of stigma around, well, certainly mental health and substance use issues, but there's a specific stigma too around suicide. So I just wanted us to take a look at this.
You know that feeling where your thoughts scare you or make life tough? Sometimes it feels like no one else in the world has those thoughts or feelings. No one seems to know how difficult it is to deal with your feelings. And it's not easy to share your deepest secrets. You might think something is wrong with you. Or you might worry what other people think. And all of that makes your thoughts and feelings worse. Our culture has created this environment of shame. Until the 1960s, society sent people away if they had challenges managing their thoughts, emotions, and behaviors. Over time, we learned that we didn't have to be afraid. We learned how to help people get better. We became hopeful. But there are remnants of those images in our culture today, which is why some people still feel uncomfortable talking about it. The stigma has taken new forms too. With more access to more people all the time, it can seem like the world is telling us it's not okay to be anything but perfect. The truth is, everyone has thoughts or feelings that can be hard to deal with. So why do we make it so difficult on ourselves by judging others who could be going through the same challenges we are? What if, instead of seeing labels, we saw people who are struggling and could be there for them so they didn't feel so alone? What if we looked past our fear of mental health and started to talk about it in a constructive way? What if, as a society, We used empowering words and healthy images to help people feel supported. Maybe then more of us could feel comfortable telling others when we're having a hard time. Maybe more people would get the help they need. And maybe one day we won't have to talk separately about mental health and physical health, but just health. The truth is, each of us has the power to change our culture. Will you join us? Share this video with a kid, your neighbor, a friend, and help us break the stigma of mental health.
So I think when we're dealing with suicide, there's a certain stigma to it. And I think one of the things we want to explore today for each of us individually is what is any stigma that we attach to suicidality, because that impacts how we're able to work with people that are dealing with that. So we'll talk more about that in a little bit. I want to run through some definitions quickly just to make sure that we're all on the same page. So first, I want to talk a little bit about attitude. So attitude technically would be, the definition would be a state of mind or feeling with regard to something particular. So there's some specific things about attitudes. So they're usually long-lasting beliefs, and they impact our beliefs and our behaviors. They're usually directed toward specific people or groups or ideas or objects. And so we all have some different attitudes about suicide. And so that's something we want to take a look at today, because again, it's going to impact how we work with people who may have some suicidality. These attitudes develop over time, and they impact how we do a lot of things in life. Usually attitudes stay with us for a long time. They're kind of hard to change, but they're not impossible to change. So one of the things I want you to think about today as we're talking about clients and what suicide looks like and some of the statistics, and we're going to talk about screening and assessment and safety plans and those things, is think about your own attitude about suicide, because that'll come out to your clients, right? So one of the problems with our attitudes is we tend to only listen to information that matches our own beliefs and our own attitude, and we just block out anything that is different. So I certainly do not want to get political today, but if you look at, I would say, both parties, if you're a Trump supporter, then things that support that, you tend to really listen to and believe, and things that don't fit that, you kind of push them away. And Republicans kind of do the same thing. What matches their beliefs about Joe Biden, for example, they're kind of like, yeah, that makes sense. And if it doesn't, they just block it out. And part of that is about their attitude. And so it's a good example of that, but it impacts what they do, right? If you think about your own political beliefs and your own attitude about politics, it impacts how you may talk to someone about that topic. So moving on, we're going to talk too about your beliefs. So beliefs are a little different than your attitude. Beliefs are the actual assumption that you have, that you hold as true. And beliefs, I think, from a therapeutic perspective, are really important to recognize that they're not always true. That's part of the reason we do therapy, is because sometimes people hold on to beliefs in their head that actually aren't valid, but they are true into their core. They're that person's reality, and so it impacts them. So beliefs come from our own real experiences, although sometimes we globalize them. So, you know, the example I always use, when I was a little girl, my grandfather, he did this lovingly, I swear, but he was a big smoker of Camel cigarettes. And he used to, when he would light his cigarette, he'd blow out the match, and then he'd hold it up to us and say, "Do you ever see a match burn twice?" And, you know, he'd hold it right to your face. And it used to scare the bejesus out of me as a little girl. And to this day, I really don't like fire. I don't like matches. Those things, there's some beliefs that I have going back to him that maybe a match would burn twice, which is totally inaccurate. But they come from real experiences, but then we sometimes globalize them into other areas. And our beliefs are a very important part of our identity. That's important to remember about your clients too. Their beliefs are an important part of their identity. But remember, they're not always accurate. But our beliefs are very, very precious, because they really do guide how we lead our lives, what decisions we make, what behaviors we have, things like that. Then we have values. So values are another step where we talk about the what has worth or importance to us, like people, concepts, or things. Our values usually are pretty stable, but they don't have real strict boundaries. So sometimes there's some gray areas. And as we move through life, sometimes our values change based on our experiences or things that happen. So if you look at this in context, our beliefs are kind of the smallest little part of this graph. And then we have all sorts of beliefs that are spiritual, moral, social, intellectual, economical, political. And then kind of an umbrella of that is our values. So from our beliefs, we create our values. And then from our values, we move on to create the attitudes that people will see from us. So people don't always know by watching us what our values are, but they know what our attitude is. And so then they can kind of figure out what our values and beliefs are from there. So I want you to keep this in context today in two ways. One is, how does this play out for a client? So if you're working with a client and you're screening or assessing for suicidality, what is their beliefs? If their belief is, I'm in a situation and I cannot get out of it, you may look at that situation and say, no, I know that you can get out of it. But if they believe they can't, we have to kind of honor that. Certain values. If people have values that they, I really would like to kill myself, but I can't because my religion says that's a sin. Those are certain values that we need to understand where the client's coming from. And then certainly the client's attitudes about even just interacting with us. And talking about what we're asking them to talk about, if we're even worthy. Sometimes people may feel like they've been let down by the mental health and the substance use system. And so we represent that. And so they may have some attitudes about that. So I want you to think about, as we talk about suicide, the context of the beliefs and the values and the attitudes of the people that you're working with. I also want you to think about it in the context of your beliefs, values, and attitudes. I have a very dear girlfriend who, at one point, she's perfectly comfortable with me sharing this. It's nobody that I'm sure you know, but anyway, when she was having some significant difficulties in her life, she said, I keep thinking about running my car into a tree. Now, she wasn't really thinking about suicide necessarily, but she was thinking about something that would kind of jar her out of the difficulty that she was dealing with. Now it would jar her into other difficulties, but regardless. But I remember when she shared that with me, and she shared that with me as a friend, not as a clinician, but she knows what I do. She was really concerned about how I was going to respond to that, and concerned that I would be like, oh my gosh, why would you ever think like that? That I would have that sort of attitude toward her, which I would never. So hopefully not toward anyone, but it's important that we take a look at our own beliefs, values, and attitudes. Here's another example. Sometimes we have clients who talk about suicide a lot. And maybe they've never followed through with any attempts, but they bring it up a lot. And that can weigh on our own beliefs and values, and therefore our attitudes. We might be saying, oh, here we go again. Here, she's talking about suicide again. She's never going to do it, but we got to go through this dance again. Some of our attitudes that we experience, it's important for us to recognize that because it impacts the work that we do. So those are some things I want you to keep an eye on today as we're talking about things as your values, your beliefs, and your attitudes around suicide and around working with clients. So a couple other definitions we want to talk about. We talk about completed suicides. Sometimes people say successful suicides, which is kind of just not the best terminology. So really the appropriate terminology would be a completed suicide, someone who has intentionally done something to harm themselves to the point of death and has been able to carry that out to its completion, would be a completed suicide. Suicidal ideation is when people have thoughts about it, and those ideations can be very minuscule. Like a lot of times in the substance use world, you'll hear people say, I don't want to kill myself, but if I don't wake up tomorrow morning, I'm okay with that. So you sometimes hear some very passive suicidal ideations, and then sometimes you hear some that are on the other end of the spectrum further down, that actually includes some planning. And so those are what we need to be real conscientious about suicidal ideations and really kind of assessing and the depth of them in that moment, and that can change. And then a suicide attempt is when someone has made some attempt to cause injury to themselves to the point of death, but maybe they have not been able to, for whatever reason, it didn't get completed. Maybe it was interrupted by someone or something. Maybe the means that they had didn't work. Maybe they changed their mind. All sorts of things could happen. This word gesture is sometimes used, and I'm a little cautious about it, but sometimes we talk about people gesturing. So they make they say they're suicidal, and they make, maybe they do a little something on the wrist, but it's so superficial that nothing would happen. And we know that, and maybe they know that. But sometimes I guess what I would caution you about is to think about your attitude, because it's something we always have to take seriously regardless. I always look at it this way. If a person is in enough emotional pain that they're willing to hurt themselves in any way, even if they're not planning to push it all the way to the point of death, if they're in that much pain that's what they have to do, whether it's to get attention or whether it's to get someone to listen or whatever, well, then we need to take that seriously and figure out what that's about. And then there's non-suicidal self-directed violence or self-mutilation. So we have cutters, and we have people that burn themselves or do other sorts of self-mutilation. And their goal is not to kill themselves. Their goal is to get some relief in the moment. And because of the way the connections are in the brain, for some people, that in some situations that gives them some relief. But their intent is not to kill themselves. We're not going to talk about this much today, these non-suicidal self-directed violence, but I think something that is important to say is that people who are hurting themselves without the intent to kill themselves, there's still danger there. For example, cutters could end up cutting too deeply or cutting in an area where they don't realize it could be dangerous. They could cut with something that's not sterile, and they could cause infection. There's all sorts of things that could happen. So it's definitely something that needs to be taken seriously and needs to be looked at. But we can't overreact that everyone who hurts themselves is trying to kill themselves. So those are some definitions just to give context to what we're talking about today. So some of the things we're going to talk about are people that have mental health disorders, substance use disorders, co-occurring disorders. Are they at higher risk for suicide? And I bet you all know the answer to that already, but we're going to talk some more about that. We are going to talk about the impact of the pandemic on suicidality. And of course, we're going to talk about what can we do to help. So I find it interesting to know that the very first suicide note that is known was written way back between 2181 and 2040 BC, so a long time ago in Egypt. It was later translated in the late 1800s by this gentleman named Adolf Ehrman, and it was called "The Dispute with His Soul of One Who is Tired of Life, or a Dispute Over Suicide." And what I think is so interesting about that title is a lot of times what we're dealing with when we're talking about suicidality is ambivalence. It's this struggle. I'm tired of life, but I'm not sure if this is what I want to do, and those types of things. So I think it's important just to recognize that suicide is not a new thing. It's not a fad. It's not a trend. It has been around for a long, long time. And that makes sense to me because from the beginning of time, there has been pain, emotional pain that people have experienced. So it makes sense that there would be some level of thoughts of suicide and attempts and completed suicides. So some of the latest statistics we have from 2018 that say that suicide is the 10th leading cause of death in the United States. About 48,344 Americans died by suicide in 2018. And there were an estimated 1.4 million suicide attempts. I would say that's probably a low estimate. Because if you think about your clients, many times people have suicidal attempts and no one knows about it. So I'd say that might be low. For every one suicide, there are about 25 attempts, and on average, there are 132 suicides each day. Again, this was 2018. Our numbers, unfortunately, have increased just based on the year, but also in the pandemic. So the rate of suicide is highest in middle-aged white men, significantly higher. If you see that, 79%. Men die by suicide over 3 times more often than women. So I'm sure you've heard this thing that say women attempt suicide more frequently, but men complete suicide more frequently. And a lot of times that has to do with with the means. Men tend to use means that are they're gonna work. They step in front of trains, they use guns, things like that. Women tend to use things like pills or other ways that may not be quite so foolproof or fatal. White males accounted for 69% of suicide deaths, and firearms accounted for about half of all suicide deaths. So when we're going to talk about firearms a couple times today, and I like to preface this because people, talk about attitudes and beliefs and values. Some people, in my experience, can get more worked up talking about guns than they can talking about suicide. And so I just want to clear the field by saying, I am not against guns. I own a gun. Sometimes I carry. This is not about gun rights. When we're talking about suicide, the reality is we're just saying that this is the fact, is that if you don't have a gun, you're not going to kill yourself with a gun. If you have a gun, that does not mean you're going to kill yourself with a gun, but the chances are greater than if you don't have a gun. It's just merely rash. It's just facts. It's not. And I just encourage you to think about your own beliefs and values and attitudes about that when we talk through these things. But the fact is, there in 2018, about half of all suicides were with a gun. So some of the important things to recognize too, we have some particular high risk folks. So our police officers who died in 2018 by suicide was more than triple that of officers that were fatally injured in the line of duty. And if you think about the work that police officers and first responders do, and if you think about some of the attitudes that they carry with them as far as counseling and getting help and things like that, it makes sense. Now, a lot of that is changing, and there's some really good work going on with that inside those first responder groups, which is fantastic. An average of 20 veterans die each day of suicide. That's another area where lots of significant emotional issues going on from things that they've experienced, protecting our country, and not as much, they don't always have the skills to deal with that. And again, in our culture, they're not always willing to reach out for help with mental health issues or substance use issues. And women veterans are more likely to die by suicide than non-veteran women. So just some things to really think about when we think about what suicide looks like. So suicide in itself is not necessarily a mental health disorder, but we know it is it is connected to people who have mental health issues, substance use issues, and co-occurring disorders. Most people who do commit suicide have a mental health disorder or a substance use disorder or both. And the majority, depressive disorder comes into play a lot of times. And we're going to talk about some more specifics about that soon. But I think that's important to remember, that you can meet a client who is suicidal, and that is not a disorder in and of itself. But it probably is connected to some other things in most cases. So we talked about those letters, that letter way back when, about the what did he call it? He was tired of life. And that plays into this thought of ambivalence when it comes to suicidality. So most people that you talk to about suicide will tell you that they're just not sure if they want to live or die. And so those are important things to kind of keep in mind. we know this because a lot of times people who've died of suicide had several hesitation wounds before they actually were completed the suicide. So that it wasn't a one and done. They had several attempts. Um, this struggle between wanting to die and wanting to live is like the core of the suicidal crisis. And that's important to remember, that struggle between wanting to live and wanting to die, that ambivalence is just really important to tap into. What are the attitudes and the beliefs and the values connected to that patient around their reasons for wanting to die, their reasons for wanting to live? Because that's so important to the work that you're going to do with them. And then we always want to remember to do everything we can to support the part of the client that wants to live, but in no way do we want to trivialize or ignore the signs of the part of them that wants to die. That's one of the things that people will say we as clinicians, we as professionals, mental health professionals, do most frequently that bothers them, is that we minimize their beliefs around why it might be better if they're dead. And so that can really play an important role in the relationship between a client and a professional, and can make things can make the client not willing to listen and to get help. So we need to be really important about that. Now part of the reason I like to talk about those attitudes, values, and beliefs early and get you to start thinking about your own is because sometimes the reason we ignore or minimize the details about why people want to die is because it makes us uncomfortable. And so I mean, there's a good reason. We're not being malicious. We're just trying to protect ourselves because we're uncomfortable, but it's not really about us. And I would say this, the issues that people have that make them support them wanting to die, those things alone, talking about those things can't hurt them. They can't hurt them. They can't hurt us. They actually are problems that we can help them maybe with some resolution and maybe change the balance. But if we start to minimize them or trivialize those things, or say, that doesn't make any sense, everybody, just because those girls made fun of you doesn't mean that other girls don't like you. You know that, right? If we start doing those types of things, we really become dismissive of the client. And we can't just focus on the parts that we're comfortable with. We have to be able to focus on the parts that we're uncomfortable with, because that's part of what makes up that person. There's some other things to remember about suicidality is it's usually a very transient state. So I've told this story to many of you who've been with me before, but there was a young woman I worked with years ago. She was 19 at the time. And when I first met with her, she shared with me that she had suicidal thoughts on a daily basis, sometimes multiple times in a day. And so of course I asked her if she had a plan, and she said she did. So her plan was to jump off the Clarion Bridge. Now, what I found so interesting about this plan of hers is, first of all, if you know anything about the Clarion Bridge, if you jump off of it, yeah, that's it. You're done. And she knew that. She also knew that it takes about 2 hours to get there. And so what she had built into her plan was some time to change her mind. I thought it was a really incredible, resilient thing that she had done. But she knew that she said that she had started on her way to the Clarion Bridge on more than one occasion, and she never made it there. At some point, things would start to change in her mind, and then she would turn around and come back. So we need to remember that the suicidality is fluid. It's not going to last. However, for any individual person, we don't know how long it might last. And we don't know if it's going to come back. So we have to remember too that it's a transient state that's not one and done. And so we're going to talk in a little bit about how we want to make sure that our work on suicidality extends beyond just the crisis. So when someone's in that transient state, usually there are some issues for them that are significantly overwhelming, and any way that we can help them with those issues can help change their kind of thought process around suicidality. So if they're using, if they have depression, if they have significant financial issues, if they have family issues, then if we can try to help them start chipping away with treatments and some work in those areas, it can change the perspective for them. And we know that cognitive behavioral therapy has been really positive in helping with people who tend to have chronic suicidal thoughts and possibly attempts. So alcohol and other drugs are a major risk factor for suicide, not just for people who have co-occurring disorders, but for regular Joe Blow down the street too, just for the general public as well. So alcohol in particular is associated with about 50% of all suicides. And not all those people have a substance use disorder, but alcohol is present in one way or the other. Now, part of that is, think about what happens when we drink. Our ambitions tend to change. Our thought process tends to change. We're not always as clear as we might be otherwise. And so something that may seem irrational when we're sober may seem extremely rational when we're not sober. And so that's an important thing to remember. That's why this is alcohol and other drugs are an issue, not just for people with mental health and substance use disorders, but for just people in general as well. A couple other points we want to talk about are that people who have substance use disorder that are in treatment, we tend to think of treatment like they're safe, and they are to an extent. But sometimes people have an increased risk of suicidality, or at least continue to be suicidal inside of treatment. And there's certainly reasons for that. For one, people don't usually go into treatment because things are good, right? So when they enter substance use treatment, they're either forced to do it by the courts or by their wife or something like that, or they've chosen to go because things have gotten so bad. So there's lots of areas there that can contribute to some suicidality, even when they're in treatment. So they may have lots of crises going on. They might be in danger of losing their job or losing their marriage. We know sometimes people go into treatment when they're trying to escape from the law. And they don't tell us that, of course, because otherwise we wouldn't keep them in those places. But they have pressures, right, that are on them, even though they're in treatment. And people tend to go into treatment when their mental health is at its worst. That's what is the motivator to push them to get there sometimes. That's the bottom, we call it. And then sometimes things that happen in treatment can increase suicide risk. For example, relapses, moving from one treatment program to another. Recently the halfway house there, the Tom Rudder House closed, at least temporarily. And so there were men there that had to move to another facility. And that could be the type of transition that's like unexpected and holy crap, what's going to happen? So those types of things can happen. The other thing is that people go into treatment sometimes and then they find out that people that have not gone into treatment are still dying. So they come into treatment and then they find out that their friend has died, and different things like that. So there's lots of reasons why we can't let our guard down just because someone comes into treatment. We have to continue to really assess and look at those things. So some clients can even be suicidal after they get clean and sober and after they get into a good solid program of recovery. And that can be really unsettling for us and certainly for them. So one of the things is that people come into treatment, to drug and alcohol treatment, and they are using substances. So they're pretty much everybody has some level of depression when they enter treatment. Some of that depression is going to go away for some of those people as the body and the mind kind of clears out. But for some of them, the depression sticks around and is separate from the substance use issue. The depression or the anxiety, those things may continue on even after the substances are out of the system. And so we need to be aware of that. There's also all sorts of other situations in the person's life that may be contributing to, even though they're clean and sober, there's still a lot of stressors in life. They may have family issues. Their wife may be keeping the kids from them. They may have some ongoing domestic violence or some sort of victimization. They may be waiting for legal things to work themselves out. So even though someone may be clean and sober and working a good program of recovery, these types of stressors can still kind of push the buttons around some of what is going on with them. And then it's important that we talk about trauma. So trauma is one of those things that if not healed, it stays with us, and it doesn't just go away sometimes. Sometimes it takes some extra effort to help it heal. And so if you have someone who has gone through treatment and they come out and they're clean and sober and they're working a good program of recovery, but they haven't addressed that trauma and allowed the head and the heart to heal, then they could have some difficulties. I always think of one gentleman that I worked with years ago who he could teach any class on addiction and recovery. He just knew everything. He knew 1,000 times more than I could ever know about addiction and recovery. But he could not stay sober one single day outside of a facility. And what I learned in looking, this is kind of what helped me recognize the importance of dealing with trauma, is that he had learned lots of skills to help him move forward in recovery, but he had never gone back and healed some things that happened to him in the Gulf War, some family things that happened to him, things that happened to him in his life of addiction. So he hadn't gone back and addressed those things. And so, that's where he really helped me kind of develop my own theory and philosophy in working with substance use disorders, that we need to teach people to move forward with skills, but we also need to go back at some point and we need to heal that story and that trauma that's back there. And the art of what we do as clinicians is knowing what's the right time to do those things. Because with trauma, sometimes if we try to dive in too quickly, it can be damaging. So there's an art to kind of knowing when to do that. But if you're dealing with a person who is clean and sober and seems to be working a good recovery program, and they're still having some suicidal thoughts, then you want to think about looking at some trauma history and helping them heal from the inside out and heal that trauma, and then continuing to help them heal from the outside in with those skills. So let's talk about some at-risk populations. We know there are certain groups of people that are higher risk for suicidality than others. Certainly, we looked in the statistics, we know that white men are particularly high risk. So we know that right off the bat. But also our older adults. So a couple things we know about our older adults is they tend to plan things out more carefully, and they tend to use more deadly weapons, deadly methods. So their wisdom works for them, and I would say maybe against them at the same time. Older adults are often less likely to be discovered and therefore rescued. So many suicide attempts are not completed because someone finds them and someone is able to then intervene and hope, and maybe intervene quickly enough that they're able to save them. A lot of times with older adults, particularly, think about this in the context of what's going on now in the pandemic, a lot of older adults are much more isolated. And so the chance to intervene is much, much less. And then our older adults, now, I hate to say this, but our older adults means 55 and older when we look in the context of these things. So pretty soon I'm going to be an older adult, but I'm not quite there yet. But if you think about your older adults, in their 60s and 70s and 80s, their physical changes and deterioration of the body, which is natural, can make suicide attempts much easier and can make recovery much, much harder. So we need to be really conscientious about our older adults. And then if you think about, again, the context of the pandemic, think about some of the places where these older adults are living, in nursing homes and places like that, where they've had a number of people come down and even die from COVID. That adds a whole nother layer of stress. And so that makes that older population more vulnerable. So it's definitely something we want to look out for. So our LGBTQIA plus population is one of the highest risks for suicidality. And so I wanted to make a comment, and maybe over in the chat, let's see, I can't see my chat right now. I'm going to find it though in a minute, but in the chat, if you're willing to share, all you have to do is say yes or no. So I was at a training the other day. I haven't said the question yet, but I was at a training the other day about LGBTQIA plus issues. And the gentleman said that it is currently appropriate to use the word queer instead of saying LGBTQIA plus. So that queer has become kind of an umbrella term for lesbian, gay, bisexual, transgender, questioning, intersex, allies, all those, and anything else. So my question to you is, because this plays into our attitudes, values, and beliefs, my question to you is, would you be comfortable using the word queer to talk about this population? So all you have to do is say yes or no. And then, because right now oh, wait, I figured out how to find my chat. Look at that. Okay. So that's our question is, would you feel comfortable using the word queer to describe the LGBTQIA plus population? So we're already getting some votes in for no, not quite yet. No, I would ask the individual, speaking to a specific individual, lots of no's. We have a couple yeses coming in, couple yeses. Okay. Another no, another yes. So what this speaker was saying the other day is that queer has become, particularly in the younger generation, an appropriate word. So I think my generation, Generation X, when I heard the word queer, it has a derogatory term. It's a derogatory term, and it has a bad context with it. And so it's not something I'm comfortable using. But it's changing. The younger generation, our millennials, our Generation Z, that word doesn't have that same context to them, which, how beautiful is that, right? They just don't see it that way. I love that. So that's just something to think about. And I don't think there's a right or wrong there. I do like the answers. A couple of you said I would ask the person that I was talking to, what their preference is, and be respectful of that. And I think that's always appropriate. So that was a nice little, I was just curious. Now I wonder if, I'd have to look at the chat to see who answered what, but I wonder if the people who said yes are some of our younger crew, and some of the people who said no are a little bit more mature. Melanie said, I recently overheard a conversation between two LGBTQIA plus where one was older and used queer and the younger one didn't like it. Interesting. Interesting. Yeah, so those are some things to just to think about it. I think a lot of the younger generation is taking back control of a word that used to be an insult. And I think you're exactly right, Marissa. That's what's happening. And I think that's a beautiful, beautiful thing. But I think we need to be comfortable using it, right? That's what I think. If I'm not comfortable using the word queer, then when I use it, that's going to show, and that may come off as disrespectful, and that's never never what I would want to do. Trisha's saying the training that she had last week, the word queer was said to still be derogatory. So I guess it depends on who you're listening to. So I'm going to err on the side of caution here with the queer word. Just because that fits in with my attitude, beliefs, and values. And let's see, Tara says, whatever the client is comfortable with. If I personally was uncomfortable and need to work through that in supervision, I recognize needing to be extra mindful when using pronouns like they or them. Absolutely. Yeah, I had a friend of mine who was working with he had a worker who was transitioning from female to male. From male to female. And so she wanted to be called she. But when my friend would talk about her, he would call him him. And I would keep correcting him. And he's like, well, I just can't get used to it. I'm like, well, I don't see the big deal. Like if your name is my son's name is William and he prefers to be called Will, like, wouldn't you just call him Will if that's his preference? Like, isn't that just to be respectful? So what's the difference? If she wants to be called she, Isn't that just being respectful? So we still have a lot of work to do in that area, right? Just as a world, I think. But what we need to remember is that the LGBTQIA plus population is extremely high risk for suicidality. So some of the statistics show that 40% of high school students who identified with these orientations stated that they had seriously considered suicide. That's almost half of the group of people. 24% had attempted suicide in the last year, and those identifying as bisexual had the highest rates of suicide. So one of the things that really impacts this population is the level of rejection that they get in our community, and more specifically from family and friends. They experience discrimination, victimization, even violence, which can impact their suicidality rate. And so some of the statistics they say is that harassment or bullying at school, 50%, doctor or healthcare provider refusing to treat them, 60%. That's appalling to me. Physical or sexual violence up to 78%, disrespected or harassed by law enforcement 61%, and homelessness 69%. So you can see if you're dealing with any of these issues, like if you go to the doctor and he won't treat you, or if you're dealing with sexual violence, your risk for suicidality is going to go up. And so that's one of the populations we need to be really conscientious and support. Age is definitely a factor. Adolescents and young adults are more likely to make non-fatal suicidal attempts. That doesn't mean we shouldn't take them seriously. Older individuals are more likely to actually complete a suicide. Women are more likely to attempt, although not as high as before. So this is kind of working its way out. Women are decreasing their number of attempts and increasing their number of completed suicides. How about men are more likely to die from suicide, and that is in all racial groups. So it doesn't really matter in racial groups there. Men are more likely to die from suicide if they attempt it. So when we talk about race and ethnicity, white and Native Americans have higher rates of suicide than our African Americans. Anxiety disorder is something really, it's an important risk factor when dealing with African American population. Anxiety disorder tends to be a precursor for many suicides in that group. There's a low prevalence of deaths by suicide amongst African American females, which I think is something we can all learn from. Historically, the African American female has been the matriarch of the family and has had to take on a lot. And so I think that leads into culturally why suicide is not an option for them. In many ways, because there's too much. They have their hands in too many pots and that they're helping take care of, and that they recognize that. So I think that's something we can learn. We can all learn from. Hispanics and Latinos have similar rates to white Americans, particularly if they've been acculturated into mainstream American culture. So there's actually some safety in some of the culture, Latino and Hispanic culture. There's actually some safety in those cultures that we don't have in American mainstream white culture. So a couple more things before we head off to take a break. Some other risk factors that are really important, and this is why it's important to get a good history when you're working with someone. And sometimes I know we ask clients about suicide history, and they're like, what are you talking about? And that's never even crossed my mind. And so that's fine. Those are good answers to get, but it's important that we know what some of their history is. But one thing we know for sure is that a prior history of suicide attempts increases the current risk of suicidality. So half of all deaths by suicide are first-time attempts. So that means the other half have tried it before and not completed it. So we want to be conscientious about that. We want to look at a family history of suicide. We know that there is some connection there. We don't totally understand that, but we know that suicidality can be generational. And so it's something we just need to be aware of. That's a tough one because a lot of times families don't talk about it, right? I think it's becoming more discussed today, but it's kind of like overdose deaths. Sometimes families just don't want to talk about it. So they say that something else happened, so that as to not maybe disgrace the person's honor, or all sorts of reasons. So sometimes we don't always get a good, accurate view of the family history of suicide. People just sometimes don't know. But we know that suicidality can be generational. And we know that there's a history of child abuse, particularly sexual abuse, that increases risks of suicidality. So those are important details. Sometimes I think when I'm meeting with a client for the first time and they're coming to me because they, they're stressed at work, I think, well, is it really important to know their suicide history? Well, but it can be. And it's not important until we need to know it. So if we don't know it, then that's when it becomes really important. There are certain personality traits that they have studied, and they still don't know exactly why, but people who are prone to negativity, like sadness, anger, anxiety, and people who have aggressive or impulsive traits are higher risk for suicidality. We talked a little bit earlier about firearm ownership, or access to a firearm does increase risk. If someone is suicidal, it increased their risk that they could potentially complete it. And we also know that people who are dealing with chronic pain, that's a significant issue that sometimes brings suicidality to the forefront. And if you think about it, I always think about when I was in labor with my firstborn, who sometimes I feel like I'm still in labor with him now that he's almost 20. But the first day I was in labor all day, and I was like, easy peasy, like, this is nothing. And then the second day, when I was still in labor, then it was getting tougher and tougher. So the longer that you're dealing with pain, the lower your tolerance gets to deal with it. That's just the way the body and the brain work. So if people are dealing with chronic pain ongoing, I talked with a patient recently who said she had a migraine headache for 4 days. And I can't, luckily for me, I cannot imagine that kind of pain for like that persistent for that long period of time. But those types of things certainly increase the risk of suicidality as well. We also know that there are certain stressful life situations that increase risk of suicidality. And I'll really think about this in the context of the pandemic right now. Unemployment, low level of education, job loss, and even retirement can cause significant stress to the point of suicidality. And so think about right now what's happening. A lot of people are unsure what's going on with their jobs. People have lost their jobs. People, all sorts of things. People have been moved into retirement earlier than they expected. All sorts of things have happened, which is part of why we're seeing that increase in suicidality now. Divorce or separation is one of the biggest losses. I had a little kid once say that he saw divorce similar to death. And I think that's probably pretty accurate in some ways. So pretty stressful. Legal situations, major or sudden financial losses can be significant. That's why we see a high rate of suicidality amongst gamblers, which we didn't mention here. I probably should have. But when they have a financial loss that's really huge and it happens quickly, it can seem like there's no way out of that. Social isolation and low social support. And again, think about that in context of what's going on right now. Lots of social isolation. People are not getting out and being able to spend time socially and kind of honoring that social part of us. We are social beings. And so there's some difficulty there. And then conflicted relationships. So I think these stressful circumstances can take anyone, even one of us. So it can take anyone, even without a history of mental health or substance use or co-occurring disorders, and can move them into a level where they may consider suicide. If they also have mental health issues or substance use issues or co-occurring disorders. I made up a new word. Did you hear that? Dis-issues. I was saying disorder and issues at the same time. But if they have those histories, then these life circumstances can be even more difficult and can increase that risk even more. So when we talk about specific mental health issues that increase the risk of suicidality, primarily we're looking at depression, and that includes substance use depression. So sometimes people say, well, the depression is because of the substance use, so it's different. It is different, but when it comes to suicidality, it's not different at all. So up to 75% of all people who die by suicide have depression diagnoses. And the higher the level of depression, the more attempts that we see. Other mental health issues that are particularly risky for suicidality would be anxiety. And that would include your post-traumatic stress disorder or anxiety with post-traumatic stress symptoms. I always like to clarify that a lot of us have post-traumatic stress symptoms, but we don't necessarily have meet the criteria for the disorder. But the symptoms, one of them being the anxiety, can certainly be an increased risk factor for suicidality. Certainly people with severe mental illness like schizophrenia or bipolar, some of those personality disorders we've talked about in the past, like borderline or antisocial, and then anorexia nervosa is the one eating disorder that we see the most suicidality with. So when you think about your clients, just think to yourself, like how many clients you deal with that have either depression, anxiety, schizophrenia, bipolar, PTSD, borderline, antisocial, or anorexia nervosa. It's like 100% of our clients, right, that have at least one of those. They might even have more. And so that's why it's important in the context of the work that we're doing that we're always screening for suicidality. And we'll talk about that after the break. When it comes to suicide, up to 27% of all deaths of people who abuse alcohol are caused by suicide. So that's not people who use the alcohol to cause the suicide, or these are people who actually have a substance use disorder and complete a suicide. Lifetime risk for suicide amongst people with a substance use disorder is about 15%. And people who inject drugs, so people who are injecting heroin or fentanyl and things like that, have a 14 times greater risk for suicide. So it's not just the alcohol. People tend to think that if they're using, that if someone's using heroin or something that's a little more of a downer, then they just kind of nod out, and their bigger risk is overdose for sure, but it does increase their risk exponentially for suicide. So we want to remember that when we're working with our substance use people. So this is a good time to get ready to take a break. Before we do, I just want to check in. Does anybody have any questions, comments, or thoughts about anything we've talked about so far? You can throw it in the chat, or if you want, you can even unmute your microphone if you wanted to throw out a question. So Paul asks, what are some reasons why white males are so likely to commit suicide and or have suicidality, especially with past trauma? Well, I think some of that, Paul, is very cultural. And it's not necessarily connected to white men as much as it is men. So let's talk about that part first. Culturally in our society, we teach our boys, now I do think this is getting a lot better, but we teach our boys who turn into men that they don't need to share, that they shouldn't share, if they keep it to themselves, stuff it down. We tend to see with men, anger is a little more acceptable than being emotionally, than crying or being depressed, those types of things. So if they're not, if culturally we don't allow our boys and who turn into men to share what's going on and the difficulties they're having, then that's going to build up, and that's part of the increase for that. Now, why it's white men over African American men or whatnot, that I couldn't actually answer for you, and I tried to look. I tried to study that a little bit to figure that out, and I couldn't figure out much. So, but we just know what the statistics say. But I think anything we can do to teach our boys and then to retrain our men that it's okay to be emotional. Maybe they have to do it in a context, but it's okay to have safe people and safe places to talk about things, even to talk about things like suicide. It's okay to talk about those things. You don't have to just keep them inside. As women, we tell our girlfriends everything. We tend to be much more comfortable communicating. We know how to communicate. We're pretty sophisticated at it. And so that gives us some healing power to it. Whereas men culturally kind of keep things more to themselves. If anybody else has some opinion on that, please, feel free to put it there in the chat. Any other questions or comments as we're moving on? chat up there. Give me a second. I'm getting there. Okay, here we go. So no questions, comments, or thoughts. Hopefully that means that everything is just making sense to you. And I do know for a lot of you, this is kind of review because we have to do it every couple of years just to make sure we keep with our regulations and things. So I do recognize that a lot of this is review. I just encourage you to be mindful about it because it is one of those things that we could get a little too comfortable with maybe, and we don't want that to happen. So some things to remember as we're talking about suicide. So we talked earlier about our attitudes, our beliefs, and our values. So those things will impact how we are when we're dealing with someone who's suicidal, and they also impact that person. So what I want you to think about here for just a moment is any scenarios that you've had where you've worked with someone who was potentially suicidal, or maybe they were, or you had concerns, maybe you were screening or assessing for that. And just think about how your own attitudes, beliefs, and values played into that. If you want to comment about that, then feel free. We can share that with everyone. But one of the things that I often think about, and this has been a long time coming for me, because our attitudes and beliefs and values change as we grow. And so one of the things, and people don't always agree with me about this, and that's okay. But when I think about suicide, I want to honor that each individual has free will and has the right to make some decisions. Now, I certainly recognize that the law says, as a licensed clinician, I cannot willingly know that someone's going to kill themselves and not do anything about it. So what I have to do legally and what I think about ethically and philosophically sometimes are a little bit different. So I never want to take away from a person that they have a right to have thoughts about suicide, and that if that's where their brain goes, that's where their brain goes. And I don't ever want to take that away from them. Now, what I would hope is that I could work with them and make their life better, so that those thoughts aren't so heavy for them. But those are some of my attitudes, beliefs, and values. As an early clinician, many years ago, my philosophy was more of, if you were suicidal, then, well, first of all, when I was back in the DNA world at the beginning, if you were suicidal, you couldn't be in the DNA world. You had to be in the mental health world. And over time, that changed for me, and is changing some for the DNA world too, because it has to. So those are just some things I want you to really think about and to remember, specific to you, that there's no right or wrong there. It's how you interpret the world. So we have to remember that suicide attempts always have to be taken seriously. And sometimes this, I think, can be difficult for us. Sometimes we may be a little casual because it's just something we're so used to, and we need to be conscientious. That's why I do think it's good that we do some training on it every year or two, because it allows for us to be a little mindful and to really focus back on this issue of suicidality, so we don't get a little too casual about it. But sometimes when someone is talking about suicide, there's a mismatch between the intent and of what they plan to do, and then what's the lethality of the method that they've chosen. And sometimes we may look at that and say, well, he says he's going to overdose on Tylenol, and that's not going to kill him. So maybe he's really not serious. We might minimize that. We need to be really conscientious about those things. So regardless, we need to take any suicide seriously, even if the risk of them being able to complete it is minimal. It's really not about the suicide, the plan. It's really about just the mere fact that someone's in so much pain that they're making a plan. That's what we're trying to alleviate, is that pain for them. And suicidal thoughts need to be taken in consideration of the person's history and what's going on with them currently. So we talked about all those high risk things that make people more vulnerable to suicide. And so some of that history we need to know. So if someone's sitting in front of us and they're talking about suicidality, and they're talking about a method that doesn't seem like it's going to be really effective from our perspective, You know, that's going to be different for someone who has a history of suicide attempts, family history of suicide attempts, co-occurring disorders, than it is going to be for someone who doesn't have any of that history there. It's also going to be different for someone who is dealing with difficulties, significant stressors right now. So someone who just lost a job, or whose wife just left him, or whose child just died, you know, it's going to be more significant for those people. So we need to look at the suicidality and context of the person's history and what's happening with them right now. So this is where we talk about screening and we talk about risk assessments. So screening, first of all, can be done really by anyone. It's a matter of just asking some questions that give you a yes or no answer. Is this person at risk for suicide? And if the answer is yes, then the screening needs to go forward to do a more thorough risk assessment. Screening should be done early, and it should be done often. So I always say there are a number of clients that I do a suicide risk screening anyway, probably every session. Sometimes I do it very formally and ask them questions. Sometimes I'm doing it kind of in incognito, maybe to say. So I'm not asking them directly, but I am assessing different answers that they're giving to fit into that screening. But a screening can be done by anyone. You don't have to have special licensure or anything like that. Now, if the screening comes out that says you think someone is potential at risk for suicide, then you need to do a risk assessment, and that should be done by someone who has been thoroughly trained. And then it is important to remember that that person shouldn't be left alone until the assessment is done. I remember years ago, a therapist had brought a patient up because the patient had said he was suicidal, and she left him in this little hallway while she came into the nursing department to tell us what was going on. And I was like, well, where's the client? And she's like, well, he's down there in the hallway. And he was fine, let's just say, but he should not have been left alone. Now, part of what happened in that scenario is that therapist said that she didn't really believe him. She thought he was just trying to get attention, trying to, you know, get out of doing some work and treatment, these types of things. So she had already kind of assessed in her own head, based on her attitudes, beliefs, and values, that it wasn't really pertinent. So she felt it was okay to leave him alone. But I would say you always need to err on the side of caution. And someone who is suicidal should not be left alone. And if you think about it, you know, we try to be really safe in our environments. Most of the time, I think we try, but there are all sorts of things in our office that a patient could get a hold of if they really wanted to hurt themselves, that they could. You know, I mean, I have tiny little scissors right here in my desk. I have mace. You know, I mean, so if I were to leave a patient in here alone, who knows what they might come up with. I have this big potted plant here next to myself that they could, you know, whack themselves in the head. All sorts of things. So we need to make sure that that client isn't left alone, so that they aren't at risk. We need to remember too that when we're dealing with suicidality, we have the immediate crisis that we have to attend to, but it is bigger than that. And this is one of the things I think we miss sometimes, because we get so like our adrenaline's running because of the crisis in the moment. And then when the crisis is done, it's like, oh, thank God, they're not going to kill themselves now. Whew. Then we kind of start to breathe again. But really, the work needs to continue after a suicide attempt has been, or suicidality has been averted. Because if it isn't, then it's very likely that it'll happen again. So part of what you're doing in the assessment is trying to find what are those core issues that are contributing to this thought process. You know, is there depression? Is there some other mental health issue? Is there substance abuse? Is there domestic violence or victimization that's going on? Have there been multiple relapses? These are the types of things that you find out in the assessment and can help you with the core of the crisis, but also then you can tackle them afterwards. Or if you're not the one to tackle them, you can get them resources so that they can get the help that they need to deal with those things. You guys, I'm sure if you've been with me before, you've heard me rant and rave about this. Suicide contracts. So first of all, let me preface by saying you always follow the regulations and the rules of your organizations. And so if your organization says they want you to write a written suicide contract, well, then you write a written suicide contract. However, this is what you need to know. Suicide contracts should never be used as a standalone intervention. They're just not effective. And they've done lots of studies on that. And so here's the thing. If a client signs a contract and says, I promise not to kill myself, and they sign it, and then they kill themselves, that contract doesn't hold up in court, right? So there are effective means of contracting, though. And we're going to talk a little bit later about safety plans, which is a form of suicide contracts that can be very, very helpful. So you just want to make sure that you're not relying too much on a safety contract. As a matter of fact, what they've found is much more effective than a written safety contract with a patient's signature is a handshake. You know, can you promise me, you know, Paul, for example, if you were my client, Paul, could you promise me that in the next 24 hours, if you are tempted to commit suicide, that we're going to reach out to this person? Can you promise me that? And then we shake hands. That is actually much more effective than some written contract. But a lot of organizations feel like the written contract covers them. It makes them feel safer. It really is. It's not good. It's not helpful necessarily therapeutically if it's just a contract. Now, safety plan is different. So there are usually a lot of warning signs that we see. Now, sometimes family members will miss the warning signs. Friends will miss the warning signs. Sometimes even as clinicians, we will miss the warning signs. You know, I always think about this gentleman that I saw at Walmart at midnight one night when I was doing late night shopping. And he had been an old halfway house client. He'd been sober for several years. And I ran into him at Walmart and I was so excited to see him. And something was just off. And I kept saying to him, are you okay? And he was like, yeah, my girlfriend's giving me a hard time and this and that. And it wasn't until the next day, like at noon, that a light bulb went off over my head. And I thought, oh my gosh, he was high. And like in the moment I was interacting with him, he was high. And I could not, you know, my brain kind of wouldn't let me go there because I did not want to believe that about him. And that's a very natural process that happens when when we care about people. It can definitely happen with family members, can definitely happen with friends. It can absolutely happen with us as clinicians too. So we need to be on high alert. Sometimes we don't notice the warning signs until after a suicide attempt or unfortunately after a completed suicide has happened. But these are some of the things that we kind of educate the general public to look at. So preoccupation with death and dying, any drastic changes in personality or behavior. Particularly, sometimes people become really happy when they have a plan. And then the family is relieved. They're like, oh, finally, they're feeling good. But there's more to it. It's much more complicated. And if you think about what we talked about with that story, that poem earlier, you know, the ambivalence of do I want to live or do I die? That struggle between, you know, being tired of living and you know, maybe thinking about dying. That struggle causes a lot of stress. Once you make a decision, gets a little easier, even if the decision is not a pretty one. So sometimes people will see some pretty drastic changes, even in a positive way in people. And we need to be just aware of that and mindful to take a look at that. Anytime someone's had a recent severe loss or threat of a loss. And the other thing to watch for losses is sometimes the anniversary dates can really be significant. So if someone lost someone, you know, for example, in 9/11, 2001, then, you know, 9/11 of 2020 may have still been a very difficult time of year. The rest of the year may have been fine, but when anniversaries come up, anniversaries of loss, they can be pretty significant. There's a whole phenomenon around that with suicidality, so you want to think about that. There's also people making what looks like unexpected preparations for death. So suddenly someone makes a will, particularly if they're young, giving away prized possessions. Previous suicide attempts we know is a risk factor. Things that are impulsive, reckless, or risk-taking that are unusual for that person. Now, you know, I've worked with a lot of substance users, and they tend to be impulsive, reckless, and risk-taking. So some of that is not uncharacteristic for them, at least not while they're using. But if you're dealing with someone and you're noticing impulsivity or risk-taking that is not common to that particular person, that's something to just look out for. And again, we don't want to overreact over any of these things. We just want to be able to honor them and take a look at them. Loss of interest in personal appearance or other things that were important, like the person isn't going to work and they used to always make sure they were on time for work, and now they're late every day or they're not going, things like that. Increased use of alcohol or other drugs. And then the biggest one I think is to recognize if you get someone talking is their sense of hopelessness about the future and that they just can't kind of get it together. So those are some general warning signs that we often see. So talking about the pandemic a little bit more, people who are particularly at risk for increased suicidality would be anyone who's contracted COVID-19, people who have pre-existing conditions or immunocompromised individuals. They tend to have more fear and anxiety around COVID, understandably. So that can increase their risk. People with histories of substance abuse during the pandemic, that's increasing. Younger people seem to have more of a concern around the pandemic than older people. And I think, I don't know if it was last time or the time before, but sometime recently I showed a graph that did talk about the population that seemed to be most fearful about COVID tend to be the millennials and the Generation Z. And then like our past our baby boomers or boomers. My son called me a boomer last night. It was kind of funny. I was like, is that like a derogatory comment when he calls me that? I think it was in that context, but regardless, our baby boomers and
it totally is a derogatory name. It's what like teenagers call anyone they think is old.
I know, right? See?
Jason, you're just mad that you get called it.
I'm not going to tell you. I'm not. That was disclosed in privacy, and I think that's a HIPAA violation right there, Chris.
It's not. I've said it to you.
So what we have found with generation is the silent generation, which is, past the baby boomers, seem to be, even though they have a lot of higher risk because of their age and their frailty, they, as far as emotionally being able to handle what's going on, they seem to show the least amount of impact of mental health compared to that younger generation. If you think about it just from a brain perspective, it kind of makes sense to me, because your younger generations just don't have the experiences. Me as a boomer, I've lived through 9/11 and I've lived through the Challenger exploded and, different things. I lived in Baltimore when we had the riots. Like, I've lived through experiences that weren't so great. I've never lived through COVID before, but there's some transferable skills that we have that younger people don't have those experiences and yet. So I think that kind of makes sense. We're seeing an increase in Black and Hispanic suicidality, and that's usually on the lower end for us, but in our country, but we're seeing an increase during the pandemic. And that may be connected to socioeconomic issues, job loss, being able to feed your family, things like that. And then of course, we have seen an increase in suicide in the elderly as well. So some of the risk factors that we know are always a high risk for suicidality, even if someone does not have co-occurring issues. So even just, regular earth person down the street, economic stress, social isolation, less access to the community, barriers to mental health treatment, and illness. So all these things are things that we're all kind of experiencing in one way or another right now during the pandemic. And so we need to just keep that in mind in context of dealing with suicidality. So this is from the CDC. They said this was some statistics during during late June. They said 40% of U.S. adults reported struggling with mental health or substance use during that small period of late June. It was like the last 10 days of June, I think it was. Oh, there it is, between June 24th and the 30th. people over age 18. So you could see people, we had an increase of just regular old people with anxiety and depression, trauma or stressor related disorders, people who started or increased their substance use. So these are not people with substance use disorder, at least not yet. And then people who seriously considered suicide. So you can see the pandemic has definitely had an impact on what's going on in the world and in our country with suicidality. So how do we deal with clients? I think we have a pretty good context now about what we want to remember and think about and about ourselves and about our clients when it comes to suicide. So now let's talk about really how to help them. First of all, it is best to talk to clients very directly about suicidality. Sometimes clinicians are concerned that what if I asked them about suicide and they weren't thinking about it? Now I've put it into their head. That is not going to happen. The research has never supported anything like that. And what is found is the more direct we can talk about suicide and about risk factors and about supportive resiliency factors, the more respectful it is to the client. And that's one thing we want to always honor is dignity of our client, regardless of what they're going through. So to be direct, you know, I always tell clients that my philosophy is always to be kind and respectful. I also have to be direct and bring up things people don't want to talk about sometimes. I think I should always do that in a kind and respectful way. And so I think that plays in here. You know, you could say to a client, I'm going to have to ask you some difficult questions, but I'm going to be as direct as I can and clear, and I'm going to be respectful because it's important. It is important to remember that the outcome of suicide does not necessarily tell the whole story. So for example, you could have a client who has significant risk and survives a suicide attempt or suicidal thoughts, never is screened, assessed, or offered any intervention. You know, people can be very resilient. And so that's why when we look at those numbers of suicide attempts and things like that, a number of them are underestimated because many people experience suicidality and they resolve it on their own. So not everybody needs intervention to be to kind of alleviate suicidality. On the other side, you could have a staff or team yourself that does everything great. You do screening, you do thorough assessment, you intervene, and the client may still complete a suicide. So a completed suicide does not mean that enough wasn't done. It's always something to review for sure, because that's how we learn. Unfortunately, sometimes we have to learn from the worst, what seems like the worst experiences. But everybody can do everything right, and the client may still complete a suicide. So interestingly enough, about 45% of people who die by suicide have talked with a PCP within the last month before their death. Yet rarely is there any documentation by the physician about questions regarding suicidal ideation during that visit. Now that doesn't mean those questions weren't asked or that it wasn't discussed, but it didn't make it into the notes. And so, you know, what that tells me is that many of these people were trying to reach out, they just didn't know how. And so they tried their PCP, but maybe that just wasn't enough. But I think it's important to remember that we have an ethical responsibility. We have a legal responsibility to take care of clients when it comes to suicidality. But we also need to remember that we are not all powerful. And so some things may happen that we are not able to control. So if a client does complete a suicide, it does not mean that we were neglectful or that we were incompetent or that we didn't handle things well. It might mean that, so we want to review it, but it doesn't necessarily mean that. And I think one of the most important things, and I talk to my staff about this from time to time when things have come up, is, you know, in private practice like we're doing here, the reality is, you know, our client is with us for an hour, you know, once a week at best. And so when that client leaves me at the end of that hour, I need to feel comfortable that in that moment, and in the very, very, very near future, like the next few minutes, they're not going to go out and do something to hurt themselves. That's my responsibility to be sure of that. And if I think that they might, then they have to keep them, have to keep them close, and keep doing whatever intervention is appropriate. But once they leave my office, lots of things could impact them and change them. So if the client leaves your office and is not suicidal, maybe they were when they came to the session, but by the time they left, they weren't. That doesn't mean that a half hour down the road, if something else might happen, that won't change. Example is this gentleman I worked with years ago. He was a hoarder and had some mental health and had a history of substance use disorder. But he said that his house was up for tax sale, and he said, if I lose my house, I'm going to kill myself. That was the breaking point. Now, he was in the midst of legal issues. He owed thousands and thousands of dollars in taxes. His house was crazy, disordered. And, but none of that was pushing him to kill himself. But if he lost the house, then he had a plan and everything. And so in working with him, what was he actively suicidal? Yeah, he was. But I also knew that because we were working with the lawyer, and the lawyer and I were working together, he was communicating with me. I knew that, when he went home tonight, he was going to be fine because nothing's happening to his house tonight. What happened in that scenario is eventually he had a plan. He was paying his back taxes. He was going to keep his house. Little by little, he stopped coming to therapy. You know how that happens, right? So he stopped coming to therapy in, let's say, April. And in, let's say it was August or September of that year, his lawyer called me and said, hey, I got a call from him this morning. And he said that there was a note on his door that his house has actually been sold. He said, so I told him I was going to take care of it, and then I'm calling you, because he knew too that was the risk factor. I reached out first to his sister, who I had consent to talk to, and said, hey, how's he doing? And she said, oh, I haven't talked to him since like Easter. So several red flags. I tried to get in touch with him. I couldn't. And so I actually ended up going to the police, and we did do a welfare check. He was in the house. He did come out, and he did agree to go to the hospital. And he did lose his house. And he was able, because of the interventions, he did not kill himself, but he did lose that house. But those are important things to remember, is that let's say he had contacted that lawyer, or let's say he found that note and called that lawyer, and that lawyer said, hey, there's nothing I can do about it. Well, that may have been it right there. And I would have had absolutely no control over that, right? So we just have to remember, one of the downsides of our work is that we want to help people so bad that we sometimes take upon more responsibility for things than is really ours. Some of it just isn't ours to take. So just remember that if you have a client, or you work with someone who has had a client who has completed a suicide, it doesn't mean that we missed something. It might mean that. So we want to evaluate it, but it doesn't necessarily mean that. So I think we need to be conscientious about that, and conscientious with each other. Those of you who are still at Gateway, if you have something happen because of the Joint Commission, they make you do I forget what that's called. They make you do they make you do some sort of analysis. Danielle, you know what I'm talking about, but they make you do this big analysis to kind of see, to put together the process to see what happened. And that always seemed to me in the past, sometimes that was a negative thing, like something bad happened, so we're going to find out who messed up. And it really shouldn't be that way, because sometimes nobody messed up. Sometimes that's just the way things happen. Now, that doesn't mean there isn't room for improvement. So I think that process can really help you pick out areas where we can always work to be better. But it doesn't mean
talking about our root cause analysis.
That's it, Danielle. Thank you. The root cause analysis.
I heard you say it's the root cause analysis, and no, we are not looking to blame anyone or provider, we are looking for, has the system
Right.
failed, or is there a gap in the system, and how do we identify that and fix it?
Absolutely. And that is the purpose, thanks Danielle, of what a root cause analysis does. It's a really excellent process. In my experience, sometimes in the old days, the way the organization that I worked for facilitated it, it didn't feel like that. And so that's something I think contributes to us sometimes in our field feeling like, well, I must have done something wrong, when sometimes we just didn't. And sometimes it is the process. Most of the times, actually, it is the process and not a particular person. So yes, thank you for that, Danielle. And Marcy, thanks for putting the words in my mouth. I couldn't remember. So this is a little something that you can remember if you're off the top of your head. This is an easy one, I think. Is path warm? So these are suicidal warning signs. So you can, if you're, if you don't have a formal tool right in front of you and something comes up, some of you are going into patients' homes and, all sorts of things. And also you have, you might be working in other roles like coaching a kid's team or doing something at church where you have some mandated reporting responsibilities now, including around suicide. So is path warm? So things you want to look at, or is this person having any ideations? Is there substance use historically or currently? Do they have a sense of purposelessness, anxiety? Do they feel trapped? Are they having hopelessness? Are they going through withdrawal, either social or isolation type of withdrawal, or are they going through substance use withdrawal, because that can increase someone's risk of suicidality? Are they dealing with anger, recklessness, and significant mood changes? So they have some nice posters on that website there, so you can grab those. And but I always think it's easy to remember is path warm. We want to also remember to look at protective factors. So they're, assessing someone for suicidality is really about taking a look at what are their risk factors, which we've talked a lot about those, but what protects them as well. So do they have reasons for living? And, sometimes people will talk about their kids, like, I'd really like to kill myself, but I can't because my kids are still young. And there's no one to take care of them, or there's no one to take care of them like I can. Pets are a big one that a lot of people will say, if something happens to me, then I can't no one's going to take care of my cat. And so pets we don't want to overlook that. Whatever the reasons are that they have for living are important. Being clean and sober can be a protective factor. It's not a guarantee, but it can be protective. If they're going to 12-step support groups, or they're attending, the next one says religious attending or religious attendance. So anything that gives them a social connectiveness, 12-step meeting, going to a group at church, going to church, belonging to a group, that is people like me, those types of things give extra resiliency and protective factors. One of the things we do look at that seems to be very strong is if people have an internalized spiritual teaching against suicide. So Catholics, for example, tend to see suicide as a sin, and that they'll go to hell potentially. And so that can be a protective factor for them, because they want to honor what has been taught to them and what their belief is. Presence of a child in the home, intact marriage, anything that's intact in the family. So intact marriage, family members that, some extended family that get together frequently, things like that. Trusting relationship with a counselor, a physician, or another service provider. This is really, really important and this is the role that we get to play. And I always say I'm kind of honored to get to play that role. But, my one patient who's extremely depressed, she says to me at the end of every session, am I going to be okay? And I always say to her, of course you're going to be okay. You're always okay. And she has said to me from time to time, Like just hearing you say that gives me, you know, some motivation to move forward a little bit, you know, for another day or another week. So it's nothing, you know, I'd like to say those are really great skills I have, and I think there are some there, but really what she responds to the most is just this connection that she and I have, this, that she trusts me and that she feels honored by me and she feels like I'm invested in her. And so she takes that very seriously. That rapport is really important. Employment can be a good protective factor, as well as this optimistic trait, just feeling that there's always going to be something, you know, things can always work out, things can always get better, things will be okay. So we don't want to ignore these protective issues either. We don't want to, you know, we said earlier, we don't want to be dismissive in any way, but we also want to be somewhat strength focused and look at these things for clients. And help them recognize them as well. So when we're looking at the risk of harm, there's a couple things we look at, a couple different levels or layers. So minimal risk of harm is if someone has no indication of suicidal. There's talks about homicidal stuff in here because I use these when we talked about violence as well, but no indication of suicidal thoughts or impulses, no history, no ideations, and no individual significant distressors. So if someone has minimal risk of harm, they're, you know, they can take care of themselves now. They've taken care of themselves in the past. You can kind of rest assured that in the moment, they're okay. That could change. Low risk of harm. So no current suicidal harm or ideations, intention, or serious distress, but they have had some transient or passive thoughts recently or in the past. So a lot of times your people who are coming into treatment to rehab, for example, are going to be in this low risk. They're not suicidal when they come in, but they've had some passive thoughts pretty recently. And so that's something to just keep an eye on. Substance use without significant episodes of potentially harmful behavior, and periods in the past of self-neglect without current evidence of such behavior. So low risk is someone who has some history in a couple different areas potentially, but you're not seeing that right now. So that can be a good thing, right? Moderate harm, as we're moving up the scale. Now you're talking about people who do have ideations. They don't have a consent. They don't have an intent. They don't have a specific plan, but they're having some pretty serious thoughts. They have some significant stressors going on. They have a history of chronic impulsive behaviors or threats around suicide. Substances are often involved at this point, and then there's some evidence of self-neglect or compromise in the ability for them to take care of themselves. So now you're moving up the scale into moderate risk. Serious risk, current suicidal ideations with specific intentions, past history of suicide attempts, and the ability, but they have an ability to contract for safety or to put together a safety plan. But it's still pretty serious. They have a history of chronic impulsive suicidal behaviors or threats, and substance use is usually involved, and they're just not caring for themselves as they have in the past. And then extreme, you know, we're just moving here up the continuum. They have a current suicidal intent with a plan. They have available means. A lot of times you might talk with a client who has a plan, but they don't have the means. I remember once I worked with a young man who said he was going to throw himself in front of a train. And I asked him which train. And he talked about this old track up in Beaver Falls somewhere. And the track actually wasn't an operating track. So no train was ever going to come. But what that did say to me is that he would figure that out and he might go find another track where there was a train. So, but we have to look at that. Like, what's their plan? And does it fit? You know, if someone says, for example, I'm going to shoot myself, well, do they own a gun or have access to a gun? If they don't, well, then that's different than yes, I'm an avid hunter or a Second Amendment guy and I got tons of guns. So there's some differences there. People in this extreme risk of harm level have history of multiple times of attempting things, sometimes involving substances, and they're not currently able to take care of themselves the way they have in the past. Things have really started to deteriorate. So here's some questions when you're doing a risk assessment that you would want to ask. And again, we talked about being very direct with the client. So one of the first things you're trying to grasp is what is wrong? So what is so bad right now that what is so painful to you that this has got you thinking about this? And really help them kind of help you understand what is so painful that this is an option, and why are other options not options at this point. The second part is why now is really, really critical, because we have people that ourselves included who have things going on long term. So it's not it's not always something new that happened. Maybe we've been dealing with something, caring for an elderly parent, for example, and being the primary caretaker. Maybe that's been going on for months, years even, and now I'm thinking about suicide. So it's important to take a look at why now, like what's different now than 2 months ago, or possibly 2 months from now, and to really help them, again, help you understand what's impacting that. You want to talk with them about what their means are. So what do they plan to do? And again, these are questions that you can ask very kindly and very respectfully, and very directly. So, if you were to kill yourself, what would your plan be? And then sometimes people don't want to talk about that. Sometimes they'll be like, well, I'm not going to tell you. I have one guy who always says to me, why would I tell you that? He's like, I'm always going to tell you I'm not suicidal, and I'm never going to tell you my real plan. And you know what, there's truth to what he's saying. Now, we've gotten to a point with our rapport that he's been able to be a little more open with me and honest. But I still don't know that he's always going to tell me the truth. And that's the other thing that impacts sometimes if we're able to intervene is, I have clients that can reach out to me at any time if they need help. They may choose not to. And so that's something that we all kind of have to deal with, is that we may want to intervene, but they may not give us the opportunity. And that's their right. So we want to talk to them about what is the means, what and where, what's the location, how far have they gone into this planning process. That gentleman I talked to you about that was a hoarder, his plan was to, he said that the lead singer or someone in the band of Boston had killed himself this way, but he locked himself in, his plan was to lock himself in a closet he had 4 bags of charcoal, and he was going to set them on, light them, and then the fumes would eventually asphyxiate him. And he had 4 bags of charcoal in that cluttered house. And actually, we worked with a hoarding team. So myself, his sister, and a hoarding organizing expert, we made up this little team with him, and we went into his house and started the process to help him with those things. And the first day I went to his house, he said, I have these 4 bags of charcoal, and I was wondering if you would take them with you. And it was really a very powerful moment, because in that moment, he had some hope that maybe he would never need those bags of charcoal. But to talk with him about, if he lost his house, that's when he was going to do it. He had the charcoal ready. He had a lighter. He had a closet. So he had a pretty solid plan of what he was going to do. And luckily, he was able to work through that. So when and where, and when and with what in the past. So to talk with them a little bit about, have you ever had thoughts like this before? Have you ever tried anything like this before? And if they have tried to attempt suicide in the past, what happened? Did someone interrupt that? Did they change their mind? Did they get nervous? Those types of things. Did someone come home unexpectedly? Those types of things, to look at what happened in the past. and the timing, what's the timing of some of their past attempts? Like what happens that makes it feel appropriate or doable now, as opposed to sometimes it doesn't feel like it's quite doable. Social response, how people responded to them after they had a suicide attempt in the past, or did they even share with anyone? And then talk about those protective factors and help them look for reasons for living and things that do protect them and make them want to stick around. And then compare their current method with any old methods. Also talk with them about who's involved. So does anybody else know what's going on? Is there anybody that could be helpful in managing this situation? What are the particular names? You know, is there a suicide pact or a murder-suicide plan? You know, if you remember a few years ago, that young woman was texting that boy and like encouraging him to kill himself. And so there's some, you know, those would be some questions, like, is there someone else involved that's pushing you to this? And then why not now? Like we asked that question, why now? So also ask, what would keep you from doing this now? And this really helps them look at protective factors and often some spiritual factors. And I know I've shared with you guys the story, and some of you were there years ago when on our biopsychosocial at Gateway, it said, have you ever thought of suicide? If no, why not? That's how the question was worded. It was not so eloquent. The spirit was there. The spirit was trying to get to, if you haven't thought about suicide, like, what are those protective factors? Like, what keeps you around? So the spirit of the question was good, just the wording of it needed to be changed. It has since been changed. So let's talk about weapons and drugs real quick. Now, remember, keep in mind your beliefs and your values and your attitudes around these types of things. But it is important and helpful if you counsel patients and their family members about the dangers of having a gun and having different various drugs. And so the drugs could be illicit drugs, but it could also be prescription drugs. So it's important to talk with the person and the family members around, whoever they're living with, about the dangers in that situation of having those things in the house. And you don't have to, you know, maybe you don't have to do anything more than just encourage them to make sure the guns are locked up and that the person who is at risk doesn't have access. Maybe you want to take the guns to a different family member's home, so they're not even in the home at all. And the same with drugs. Like if you have drugs in your medicine cabinet that you're not using anymore, then discard them, you know, or lock them up. Anything to do to keep people a little more safe. So there was this study in the mid-2000s in Switzerland where they effectively cut in half the number of soldiers with guns stored in their house. And that research showed that the decrease in gun ownership and gun access resulted also in a significant decrease in suicide. So it's not always the direct correlation, but there's some correlation there. And the same with drugs and medication. Again, if they're the less accessible, I mean, there's always going to be something, but the less accessible, the harder someone has to work, then that time, it gives them time, and that time can really help and allow things to unfold. That's an important thing. So let's talk about safety plans. Oprah says, you get a safety plan, and you get a safety plan, and you get a safety plan, which I think is always a good policy. So if you guys were here, like if we were in person, I was going to put, I think Jen suggested we were going to put safety plans under all your chairs. So we could be like, look under your chair, what's under there for you? But we're virtual, so you'll have to pretend. So a safety plan is very different than a suicide contract. So a safety plan is a written, prioritized list of coping strategies and resources that a person can use either during or before a suicidal crisis. And so a safety plan should be brief, should be in the patient's own words and easy to read. So one of the downsides I've seen in the past with safety plans is they're written by us as clinicians. And sometimes as clinicians, we like to use big words because we think we're fancy. And, but then, and so clients won't always say to us, I don't know what that means, or I don't understand that. So make sure it's in the client's words, because in a moment of crisis, either before or during, we don't want them to have to go, find a Webster's dictionary to figure out what they're supposed to do. So make sure it's easy to read, make sure it's brief, make sure it's in the patient's own words. And then part of the way we develop a safety plan is we really listen to the client, we empathize with them, we engage them. And by doing all those things, it increases the likelihood that they will actually use the safety plan. Because remember, a safety plan is just a plan. If it's not put into place at the appropriate time, it just sits on a piece of paper and looks pretty. So we want to increase the chances that a client will actually use the safety plan. And so all these things, having it written down, having it be brief, making sure it's in the client's words, easy to read, developing it with them together, and really engaging the client in the process can definitely help and increase the likelihood that they'll actually use it, which is what we want, right? Problem solve with the patient to identify any barriers or obstacles to using the plan. So if there's a really good solid safety plan, and one of the things on the safety plan is if I'm starting to feel depressed and start to think about suicidal things, I'm going to call my sponsor. That's a great plan. Great plan. So what if their sponsor isn't available? So to really think through, okay, what would you do then? And that's why having a we is always important, because we can't just rely just on one person, because everybody has stuff going on. Talk with the patient about where they're going to put the safety plan and how they're going to locate it during a crisis. And a lot of people now will keep it in their phone. There's lots of great opportunities for people to figure out what's best for the client. I had a client once who carried her safety plan in her purse for like years even. And at one point I said to her, she pulled it out of her purse once, and it was well beyond the time that we had put it together. And I was actually fascinated that she had it still. I had almost forgotten about it. And she pulled it out of her purse, and it was all crinkled and whatnot. And but she said just having it in there, she never even really looked at it, but just knowing it was there was helpful for her. It was something physical and tangible if she needed it, and just knowing it was there was helpful. So thinking those things through with the client is really important. Evaluate the format, make sure it's appropriate, that the patient understands it, and that it fits their circumstances. So that's where you have to be careful if you pull, or if your organization uses like a template for a safety plan. That's not a terrible thing. It's a good starting point, but you need to make sure it's really individualized. Otherwise, it may not fit for them. And then you need to review the plan from time to time, because new barriers may have come up. Something in the plan may not work anymore. Something may need to change. So you want to make sure that you're reviewing that with the client from time to time. Okay, questions, thoughts, or comments as we go on? I'm going to take my screen away here, if I remember how. Yes, there it is. Okay, what I'd like to do next is run through a couple scenarios. And I'm going to ask for some volunteers. So before we do, I'm going to get over here to, we have a couple comments. So Paul says, if there are males who commit suicide, is there more outreach for them here in Pennsylvania and abroad? That's a good question that I don't know the specific answers to, because I think when we deal with suicidality, we try to be very non-discriminatory and to screen everyone. We know that there's some higher risk, and that impacts our screening and assessment process, but everybody gets screened. So I don't know that there's any difference in that. As far as outreach, I'm not sure. This is a good time, though, to talk about briefly. I wanted to mention Beaver County is involved with a Zero Suicide initiative. And I brought this up on my phone because I wanted to share something with you. So the Zero Suicide Initiative is really just what it says. That's its goal, is to get to zero suicides. They're leading system of care change and culture change, training the workforce, helping identify individuals, engaging individuals, treating, transitioning individuals through the process, and improving policies and procedures. If you go to the Zero Suicide, if you just Google it, they have some really great toolbox. They have fact sheets, all kinds of stuff. There's also good information on the Beaver County System of Care website. But the one thing I wanted to mention, Paul, that I think touches what you were saying is that the gentleman that they had come out and speak, and of course his name is going to elude me right now. Jen, what was the guy's name who came? He had jumped off, he had attempted suicide by jumping off the Golden Gate Bridge. What was his name?
Kevin Hines.
There you go.
Kevin Hines. Thank you, Danielle. Yeah. So I think he did come and speak to us. He has a book, he has a film, and some really good resources. And he is a white male, so that might be some good outreach. And then Paul also says, as a peer specialist, are there things a certified peer specialist can do with a person with suicidality and or a person expresses they're wanting to commit suicide that may differ from other mental health professionals? Well, I think as a peer specialist, the primary thing you're going to do is screen. And you may do some good assessment work, but the screening is the most important part that you're going to do. The good thing about what you guys do as peer specialists is that you're out there in the world with them. So, I had to kind of wait till my patient comes into the office. And if he doesn't come into the office, I'm kind of stuck. Whereas you as peer specialists often go into the community, into the person's home, find them where, meet them where they are, which is a much more genuine place to do a screening for suicidality, right? If you think about it, the person who comes to my office for their appointment may be suicidal, but the mere fact that they came to my office for their appointment says something about them wanting to have some intervention, right? So if they don't show up in my office, then that may mean they were not open to intervention, and then I don't even get the opportunity. So as a peer specialist, you're out there in the community, and you're able to do that assessment. And I think the most important part, Paul, would be to make sure if you have concerns that someone is suicidal, that again, you don't leave them alone, and you get them to someone or to some place that can take care of that. And that can be tricky because sometimes people don't want that, right? The other thing that happens is I had a woman years ago who I had to call the police, and we had to 302 her because she was suicidal and she had taken a bunch of pills. And I called to follow up with her at the hospital and see how she was doing. And she was very sweet, but she said, my husband's really mad because I don't have insurance to cover this. We're going to get a big fat bill, just like last time. This was not the first time this happened to her. She said, my husband's really angry at me. She's like, and I can't believe you did this. I wish you would have let me die, and I'm not coming back to see you. And she didn't. She didn't come back to see me. So we have to remember that too, that sometimes when people are dealing with suicidality and we do what we need to do and what we think is right, it may impact the relationship we have with that person in the future forever. And that's just a reality of it. So hopefully that helps a little bit, Paul.
Hey, Jill.
Yes.
Can I ask you, I just wanted to make a statement or a question. Can a CPS do a safety plan with a person, or is that strictly for clinicians or, mental health professionals other than the CPS?
Well, I would say that the CPS can contribute to the safety plan. Absolutely. Safety plan, you probably do want some guidance from a clinician. And the only reason for that is because they have more training, which really covers you with liability. Because the reality, Paul, is that many peer specialists can do a safety plan just as well as I can with a million letters after my name. But the reality is the license that I have gives me some protection that you don't have as a CPS. Does that make sense?
Yes.
But I think that the work that the peer specialists are doing sometimes is actually more helpful to the development of a safety plan, So I would say that the role is definitely for the peer specialist to contribute to the safety plan, because you're going to know things that my client may not have shared in a session, that you're going to know, maybe even just from observation. If you go to the client's home or you see them in a meeting, and you see who they're hanging out with, then you may have some more information that client didn't share. So I definitely think you want to be a part of it. But for liability reasons, I think you want to do that in conjunction with a clinician, so that you don't get some of that liability.
Okay, thank you.
Yeah. Anybody else have any questions you want to shout out or throw into the chat real quick? All right, so I have a couple scenarios, that I want us to talk through. So I'd like a volunteer, but I will pick on people if I have to. But is someone willing to unmute themselves and listen to a case study and then give us your ideas about risk factors and resiliency factors and what to do next? Don't all jump at once.
If no one else wants to play with you, Joe, I'll play.
Is that Jason?
Yeah.
Thank you. All right, Jason. So listen, we have
and if you want to feel mean, you can always, I'll just unmute and you can feel free to pick on me and I'll throw a temper tantrum like I don't like it.
Okay. Okay. So listen to this, Jason. We have a 37-year-old white female who referred herself to the emergency room. She stated that her plan is to drive her car off of a bridge. The precipitant seems to be verbal abuse by her boss. After talking to her nightly for hours, he suddenly refused to talk to her. As a result, the patient feels angry and hurt and threatened to kill herself. She is also angry at her mother, who will not let her smoke or bring men to their home. Her current level of alcohol is 0.15. She is confused, repetitive. Her history reveals a previous suicide attempt of an overdose about 7 years ago, which did result in hospitalization. After she spent the night in the ER and sobered up, she said that she was no longer suicidal. So what do you think are some of the risk factors there?
Definitely the earlier or prior attempt. That means like it was with pills. She's just changing the mode. I would want to find out a little bit more about that information, like how, like why didn't it work, I guess, and maybe like by her driving, like she's upping her means, so that's a red flag to me. Like Absolutely. If she was like the car off the bridge would definitely, it's a red flag, especially depending on how high the bridge is. That's going to be pretty. It's not successful. It was completed. So that would definitely be red flags. I mean, I would try to get a hold of someone that she cares about, or try to find something positive in her that she can hang on to or check in, and that so she can't, in case she can't check in with the therapist all the time. Maybe she does need to be hospitalized for a little while, possibly. Definitely talk to someone at work. Well, I wouldn't, but I would encourage her to talk to HR to try to get things, help her straighten out at work. If her bosses are bullying her or whatever, that's something to kind of try to help alleviate that, and try. And then with mom, maybe check in with her and talk to mom about, see if it's okay to talk with mom and make mom realize what's going on. Like, I don't think that's the stuff. Just hopefully mom's a good support for her. Like, I don't necessarily, it's mom's house. If she doesn't want men and smoke in her house, I'm totally on board with that. I don't want my daughter bringing men into the house. So, there's nothing wrong with that. Right.
Right. It's hard to tell from the context there. Yeah, it's also kind of hard to tell, like the boss, like she's talking to her boss every night and then suddenly he refuses to talk to her. Like, is there more to that? Yeah. So there's some things that we would definitely need more information about. Jason, do you see any resiliency factors here or anything positive that could be helpful for her?
I think she's definitely reaching out for help still. She's still talking to us. about it. She went to the hospital.
Mhm.
She's seeking help. So it sounds like, while she's upping the ante, it sounds like she's also crying out for help. And it
Yeah.
thinks that if she gets the right preventative factors and positive things in her life, she'll be all right.
Yeah. And then the idea that she, the next day after she sobered up, she says she's not suicidal anymore, really may be, the alcohol might really impact her.
Absolutely. Yeah. That's it's a depressant. So it's like,
Yeah.
it just
Excellent.
adds fuel to the sadness fire.
Right. Right. Anybody else have anything to add? Thanks for doing that, Jason. Anyone else have anything to add, or
You're most welcome.
nothing else on that one?
She's likely to be drunk again soon.
I think she definitely is someone that we need to look at a substance use assessment for sure. And then probably just a COD assessment to look at, which comes first, the chicken or the egg, is sometimes hard to decide. Is she drinking too much and that's making her anxious and kind of overreacting to things, or is there some other mental health stuff going on there as well? Definitely. Do we have another volunteer? Anybody who works with kids or youngsters? You're going to make me pick somebody.
Okay, Jill, I'm in.
All right, Dawn, thank
I don't
you.
work with kids now, but I've worked with them for
But you have.
a lot of times.
Okay. So we have a 16-year-old Native American female, self-referred following an overdose of 12 aspirins. She said she could no longer tolerate rumors at school that she and another girl are sharing the same boyfriend. She denies being suicidal now and says, "I won't do it again. I learned my lesson." Reports that she's always had difficulty expressing her feelings. When you're talking with her, she presents as quiet, guarded, and initially very reluctant to talk. So what are your concerns there with her, Dawn?
I guess first that she won't share her feelings and won't talk. My concerns are that the things that are happening at school are not going to change probably. I'm wondering if she has any friends or anybody that can relate to at all, because if not, then there's going to have to be a professional friend to hook her up with. The young folks who are Native American that I've worked with tend to have this sense of inferiority, like a complex. So it's like when kids pick on me, I deserve it. I've worked with a couple of young fellows like that. I'm not a female, and so that self-esteem thing is an issue, and I'm sure it's an issue in suicidality. What else concerns?
What do you think about her saying, "I won't do it again. I learned my lesson"?
That very well could be the push away. Leave me alone. I'm okay. I'm not going to talk about it, rather than anything that she's really confident about. So I would probably want to investigate that. Would also investigate maybe why she chose aspirin, because I'm not sure aspirin. I don't know at what point aspirin becomes lethal, and did she investigate that? Did she look on the internet to find out how much to take? What was the planning that went into it? How impulsive was the act?
Yeah, that's good. Do you see any resiliency factors for her? Protective factors?
I'm sure there are, but I don't see them.
Yeah,
So
not
I guess
in what's
that's something we'd have to talk about,
right.
dig around about.
Good. Excellent, Dawn. Thank you. Anybody want to share anything or have any additional comments about our 16-year-old Native American female? All right, I want to go through one more. So we need one more volunteer.
I
Oh,
can go.
that's true. Okay, thanks, Rachel. Real quick, I see Jen, our background support here. She did point out that our 16-year-old Native American female self-referred after her overdose. So that could be a factor there, definitely. Thanks for picking that up, Jen. Jen's always looking for the bright side. All right, Rachel, are you in your car?
I am in my car. I'm moving this week, so I'm using my time as wisely as possible.
Okay. Well, don't crash.
I won't. I won't.
Okay, so this is a 23-year-old white male, self-referred. The patient bought a gun 2 months ago to kill himself and claims to have the gun and 4 shells in his car. Police found the gun, but no shells. Patient reports having a planned time and place for suicide several times in the past. States he cannot live anymore with his emotional pain since his wife left him 3 years ago. This pain has increased during the last week, but the patient cannot pinpoint any precipitant. He has a history of chemical dependency, but has been sober for 20 months and currently goes to AA. So what are your concerns, Rachel?
Obviously, my number one concern is going to be the gun in the car, with or without shells. Concerned that he doesn't seem to have any natural supports if his wife is, gone. It's good that he doesn't have that. It's good that he's sober. Especially, I don't know if he's involved with like AA or NA or anything. That could be a good support. How old did you say he was?
He's 23.
Yeah, that's awfully young.
Mm-hmm.
And how did you find out about him, the police?
Well, he was a self-referral, but somehow the police did know about the gun, but they didn't find the shells.
Okay. I mean, the shells could just be hidden or somewhere else, but I think my main thing is that there seems to be such a solid plan for somebody who has had just one thing after another, and at that point, in such like a delicate state, it could be any small thing. It doesn't have to be one big precipitating factor or event that would lead him to anything. It could just be, gets yelled at for being late to work or something. It could be anything small that would normally not really matter.
Yeah. Absolutely. Thanks, Rachel. Anybody have anything they want to add about our 23-year-old white male here?
I think I would want to know, he's had the gun for 2 months. What's kept him from using it in that 2 months for resiliency? There's the protective factors.
Absolutely. And then I think too, looking at his wife left him 3 years ago, and something in the past week made this unbearable to him. So kind of trying to explore that a little bit more. But it also tells me that he may not have the best overall coping skills if after 3 years he's still not over his wife leaving. So yeah, and it does say that he is going to AA. So that's something I would explore with him, like how involved, people say they're going to AA, and that means different things to different people, right? So like, is he going to AA, or is he actually engaged in a recovery program? Because they're very different things. So those are definitely things to explore. What kind of questions, comments, or thoughts do you have about anything that we've talked about today, or anything that maybe we didn't cover today that you were hoping we would cover? You can either unmute, or you can go ahead and put it in the chat if there's anything. Okay, I think we're pretty good. It looks like Rachel might be connecting to her audio. Maybe she has something she wants to say. So I don't want to wrap up too quick.
I didn't do it.
Yeah, you didn't do it. Okay. Okay. All right. So I think the things I would encourage that I'm hoping you're going to leave here with today is taking a look at yourself. What kind of beliefs and values and attitudes do you have around suicidality? How does that impact work that you do with clients? And do you feel comfortable? You know, one of the things I learned the hard way, not super hard, but hard enough, was being prepared is, you know, this is the Boy Scouts right here, you know, always be prepared. This is one of those areas where you don't want to wait till something happens to learn, to find out if you have the skills to work with someone who's suicidal. You want to make sure that you're learning as much as you can and that you feel comfortable, because you never know when this situation is going to come up. And when I say that I learned the hard way, you know, when I opened my practice, we didn't used to ask for an emergency contact. I just didn't think we would need to in this level of care. But I had a woman who contacted me, a patient. She had taken a bunch of pills. She told me she was at some place in Robinson cleaning some building, but I didn't know where she was. And then she got off the phone because she was tired, and she said she was going to take a nap. And so I had to reach out, and I had to go and find a way. You know, I had to Google and get a number for her husband, call him. He was unfortunately not helpful. So I ended up, but he at least was able to tell me where she was. And so then I called the police to get them there. And she had taken a bunch of pills, and by the time they got her into the ambulance, she had passed out. So the timing was really good. But I learned from that point, that's why you have an emergency contact, is so that you don't have to find out where that person is in an emergency. So, you know, learn from that, take a look at your own skills, and think about it right now in the terms of the pandemic, that we need to be assessing even more frequently than we used to, because times are changing. So if you guys don't have anything else, Jen is going to put